everybody, and welcome to Community Conversations. My name is Luke Margolis. I'm the Corporate Communications Director for Atlantic Health System. And on today's episode, I'm excited to be joined by Dr. Naeem Rahman, the Medical Director for AMG Urology at Summit Bridgewater. Dr. Rahman, good to see you, sir.
Thank you for having me, Luke.
All right, folks. Well, here we are coming to you in the month of September. Which is Prostate Cancer Awareness Month. So if you didn't see the title of this link before you clicked on it, we'll give it away to you right now. Today we are going to be discussing prostate cancer and the information you need to know as patients and some of the ways Dr. Rahman and the team here at Atlantic Health System are helping patients with prostate cancer. So little housekeeping before we jump in, just to let folks know, you can see all of our community conversations by subscribing to our YouTube channel, which I certainly hope you do, because it's not just these, but all of the amazing content our team puts out here will be available to you that way. But you can also go to our website, atlantichealth.org, where in addition to all the other amazing information, you can find links to this show and all the other ones we've done. And we've done about 40 of these now, covering all kinds of different topics. So be sure to check that out. All right, with all that having been said, let's jump into it.
Great.
Prostate Cancer Awareness Month. I think let's start at a high level and then we'll drill down as we go. What are some of the top line takeaways? What are some of the things you want people to think about when we enter into a ceremonial month like this?
I think the biggest thing is that it's very prevalent. I mean, it's the most common solid organ cancer in men, and the numbers are just getting bigger every year.
Wow.
Each year, there's well over 200,000 men in the United States that get diagnosed. This year, they're predicting about 290,000 men being diagnosed with prostate cancer. 10 years ago, it was about 210,000. So the numbers seem to be going up. It's more and more prevalent. It's very common, and it's very treatable. So I think having that combination is important, which lends itself to say that if you screen for this earlier, you're going to probably have better outcomes. So I think the take-home message is that this is common. It's very treatable if you get screened appropriately.
How good is the field at screening? Like, as an industry, how good are we in the States in detecting these things in people?
We're very good because we have excellent tools, and the principal tool is the PSA test. In fact, some would argue we're almost too good, and there was some pushback maybe 5 to 10 years ago, and maybe still a little bit, that perhaps we're detecting cancer at a higher rate than we need to, because some of these cancers may never harm the patient, but we may be introducing some harm by diagnosing and treating things that may not be potentially harmful. There's probably a little bit of a grain of truth in that, but on the whole, urologists and I think most people who are experts in prostate cancer feel that we could probably parse through those patients that have a lower risk once they're diagnosed and not necessarily treat those, and we still want to find those patients that we can help.
They really need our help.
They are very treatable, very curable, and there may be a subset that may not need treatment, but knowing that ahead of time is very difficult. So a broad screening strategy is still very important.
So you said PSA,
prostate specific antigen. That's the principal way that we, as well as nations throughout the world, diagnose prostate cancer.
Is that through a urinalysis or a physical examination? What goes into that?
It's a blood test that can be ordered usually by your primary care doctor.
So pretty easy to do, right? No reason why folks would need to be afraid of going through a test like that or anything along those lines.
Exactly, very easy.
One of the things because we've had a number of conversations with oncologists and folks who are in the cancer space on this program before, and we try to talk about things like how can people know what to expect, right? What predisposition for these kinds of things? Is there any evidence that gives folks some intel on what they can expect as they age? Is family history a big deal? What are some things people need to keep in mind when they think about this?
So family history is super important. So if you have a family history of prostate cancer, particularly in what we call a first degree relative, i.e. father or brother, your risks increase. If you have multiple first degree relatives, a couple of brothers that have had prostate cancer, and we see these patients, your risks increase proportionately. But it's not just prostate cancer. If you have a history of breast cancer, there's definitely a correlation between breast cancer and prostate cancer linking in families. There's other cancers that can be linked in, pancreatic, melanoma. A lot of these cancers can cluster in families. So it's not just your prostate cancer history, it's broadly, is there a cancer history? That will certainly increase your risk. The other big thing is ethnic group. We know men of African heritage have a higher risk for prostate cancer, and that's globally, certainly in the United States as well. And we also know that they tend to have a higher rate of mortality from prostate cancer. So that is considered another high-risk population. So we would want these men to be screened at an earlier stage as well. So I think family history, ethnic group are big. And then broadly speaking, as you get older, your risk will also increase. So as one ages, one needs to start thinking about getting screened for prostate cancer.
When do you want folks doing that?
Well, different organizations have different recommendations. I think as a general population, most people would say start around age 50 unless you have a family history of prostate cancer, then you want to start earlier. Or if you're an African American, you probably want to start earlier, like in your 40s. More and more, there's data that if you start in your 40s, it's actually a very powerful tool. Getting a PSA in your 40s helps to predict cancer much, much later in life. In fact, there's some data that knowing what your baseline PSA at the very start is even more powerful than family history and ethnic background. And I can just tell you what I did for myself and what other urologists I know do. And I started when I was 40. Now, that's not a national guideline. But honestly, if you speak to most urologists who are on the field that are male, most of them have started early as well.
Jump on it.
Yeah, I know my brother's a urologist. I know he started early. Many, many friends are urologists of mine, colleagues. Most urologists probably will start in their 40s just because there is an advantage to know what your risk is early on. And we always we've seen cases where the cancer has been super aggressive, and knowing earlier is always better.
No, just power, folks. We may have some folks out there saying, well, I don't have a urologist. Well, if you're looking for one, or if you need those types of connections, maybe you even need a primary care physician. Go to our website, atlantichealth.org, the Find a Doc tab at the top. You can search by specialty, geography, spoken language, anything you want, and that can help you find somebody for you to consult with and help get this testing done so you can stay ahead of it as we're talking about here. Okay, so let's jump ahead and assume person X, whoever, has been diagnosed. What happens now?
Well, that's a more complex question, and I think it's very nuanced depending on the individual characteristics.
Sure.
It's going to depend on your family history. It's going to depend on your age at diagnosis. It's going to depend on what your number is, your PSA, what the absolute number is. It's going to depend on how many areas come back positive and how aggressive those areas look. Okay. So it can range from observation. I would tell you that, a quarter of the time we're going to tell patients that you may not need to do anything for your prostate cancer, that we can probably safely observe this, and you may have many, many years of observation and not subject yourself to any of the treatment side effects. The other end of the spectrum, if it's more aggressive, it's going to be possibly surgery, possibly hormonal medications, and if it's super aggressive where it's already advanced, there are treatments such as chemotherapy and other avenues. So I think the take-home message would be that it's very nuanced, it's very much tailored to your individual risks, and the other take-home is that prostate cancer is very heterogeneous. So there's going to be a subset that is not going to require treatment, and there's going to be a subset that's going to be lethal. And trying to parse through that is really what our role is as urologists and people who are experts in the field.
So it is not the same for everybody, no matter what. You may know somebody in your life who has prostate cancer. Their experience may not necessarily mirror what you would deal with then.
I think I would go further. It probably is not going to mirror your experience. Okay. I mean, it's the same number, the same parameters. In one patient may have a very different implication just depending on their own personal risk profile.
Folks, one thing I neglected to mention early on, but certainly hope you'll take advantage of, is the doctor and I are certainly having our conversation, but you're involved too. If you have questions about anything we're talking about, or maybe you want a little clarity around something, or even just want to reach out with some generalized questions, please feel free to do so. You'll see the chat function on your screen. You can put it in right there. We are monitoring that. We'll get to as many of those as we can. Do me a favor. Keep it on topic, right? We're here to talk about a very specific issue today. So, but please feel free to put any questions you have in there, and we will try to address those as we go. Let's talk a little bit about some of the improvements we've seen over time, because I think often people find reassurance in knowing that maybe their grandfather had a certain incident, and while his circumstance may not be identical, the treatment he went through was significant on his quality of life. How different are we now versus where we were years ago? And talk a little bit about the progression we've seen in care, and whether that's care we provide here or just in general.
I think that's a great point. So I touched on a little bit of the development is that we're probably able to decide with a lot more certainty who doesn't need treatment.
Right.
And maybe 40 years ago, everybody got lumped into treatment, and maybe some of these patients didn't need treatment. So I think one hallmark of where we are is that we can probably stratify a lot better than what we did. Okay. And if we talk about the different treatment approaches, I think each aspect has been refined. So if you take something like what I do, surgery, 40 years ago, 50 years ago, prostate surgery was very, very bloody. The transfusion rates were super high. The risks of certain things like incontinence and impotence were super high. Over the years, we've developed techniques and technologies that have improved that vastly. Robotic surgery has been around for about 15 or 20 years, and most urologists now utilize robotic surgery to help refine the technique of their surgery, which helps to reduce blood loss, improves pain control afterwards, improves their recovery, so they're not having weeks on end of recovery. The recovery time is much shorter, and the risks of incontinence and impotence and these kind of side effects that we see is also reduced over time. So we've definitely made headways with that. If you talk about different formats of radiation, that is also, we can echo some of those same principles. We're refining our radiation techniques, certainly with the implementation of CyberKnife and things like that. We're making it more efficient. If we take it even further, when we're talking more advanced cancer, when we're talking about hormone therapy or chemotherapy, there have been innumerable advances with new drugs that have come on the market, even since I've practiced. There's, 20 years ago, we had maybe one drug we could give you, or two drugs when the cancer was super advanced. Now we have a half a dozen or more. So, and I think at each level of someone's care, we have advancement of therapy, advancement of care that are going to improve your survival and improve your quality of life.
Interesting. Folks, if you're looking for more information about some of the treatments that we're talking about and our program here at Atlantic Health in general, go to atlantichealth.org/prostate. It's real easy to remember URL. That'll get you connected with our team, and you'll be able to find some information there that might be particularly helpful to you in both articulating what challenges may lay ahead for you and the ways in which we can help. Doctor, before we began our program, you and I were talking a little bit about a term that I think is interesting and maybe worth diving into here, and that's a multidisciplinary team. It's something I've talked about on other shows and in other capacities, but I'm curious, how do you see, or what does our multidisciplinary team consist of, and why is structuring the team that way of value to patients as we try to help them?
So, one thing is when you get diagnosed with prostate cancer, there's a lot of different things thrown at you, right? There you have a lot of different options. There's not a XYZ algorithm that you need to follow. You'll get opinions regarding radiation, you'll get opinions regarding surgery and hormones, and it can be kind of a maze. And so we have a multidisciplinary clinic in my practice that I share with the radiation oncologists. And we meet twice a month, and it's the radiation oncologist, myself, a nurse navigator that are meeting with the newly diagnosed patients with prostate cancer. So they get to meet us firsthand at the same time. So it's efficiency of care. You're not going to several different offices. Two, you're getting collegiality of care because I have a very good rapport with the radiation oncologist and vice versa. And we try to really kind of put our personal biases aside about what we might think is the best treatment and really just hone in on what is the best thing for that particular patient. The third thing is we have a nurse navigator and other resources that we provide the patients. And this helps to streamline their care. They get the personal number for the nurse navigator, so that bypasses a lot of things like being put on hold for different studies and other things that sometimes can be frustrating in the medical system. So I think what we're doing is giving them resources to streamline their care, to give them what we think is the best possible opinion at one setting, and hopefully with that, the information, they can come up with what's the best treatment for them.
Making healthy easier, as we try to do. Remember, folks, if you got any questions about anything we're talking about, please feel free to put them into the chat. We always try to empower people with information that they can use to better themselves as well. And I'm wondering, if you had any thoughts around, lifestyle things, is there anything people can do to maintain prostate health? Are there, whether it's cancer or just urologic issues in general, what do you recommend for people to do, for men to do in their lives to try to stay healthy and push off any challenges that might come their way?
So one thing is, a lot of this is not in your control, right? We already talked about genetics and things like that. So I always tell, like, a lot of times we'll give this diagnosis to men who are super healthy. They're really taking good care of themselves, and they almost feel guilty that, hey, what did I do?
What did I miss?
What did I miss? I take care of myself. I go to the doctor. I eat healthy. I work out. So I think one component is always to remember there's only so much you can control. The flip side of this is that across the board, we are seeing increases in cancer diagnosis. I started the conversation by saying we're seeing increases in numbers for prostate cancer year over year. That's not just true for prostate. That's true for almost every cancer that you can talk about here in the U.S. So there's probably something in our environment that is pushing that, and whether it's our lifestyle choices for food and diet and exercise or stress or sleep. There are probably variables here that are probably contributing. It's like so many other things. Just exercise the golden rule of moderation, right? So be mindful of your diet, of your health, of your blood pressure, of your diabetes risk. Make sure you're getting exercise. Make sure you're socially engaged with your family, with your community. All these things are part of good health that I think need to be emphasized across the board. So I think broadly speaking, just do the things that your primary care doctor tells you. Eat a heart healthy diet. They usually say heart healthy is prostate friendly. So that's usually a good catchphrase. Like, think about what your doctor tells you for your heart. Keep your saturated fats low. Keep your animal protein levels lower. In general, probably becoming more of a plant-based eater as you get older is probably a smarter idea. I'm not saying you have to become a vegan or vegetarian, but just kind of transition slowly into those kind of things. There's ample data that's helpful for longevity. If you look at cultures that live a long time, these blue zone cultures that are advertised, that's
the diets associated with those cultures.
The diets associated with those cultures are often plant-based, often a lot less meat than what we are traditionally eating. And the other thing is they're probably eating a lot less than we traditionally eat, which we've talked amply in other avenues about an obesity epidemic. So part of that is also, what are the proportions that we're eating relative to other places that are healthier?
Easier said than done sometimes. Heart healthy is prostate
friendly.
Yeah. You should get bumper stickers or something like that. That's a good one. I like that.
Maybe I should TM that.
Exactly. All right. We are coming down the home stretch. We're almost out of time. Just the PSA test. Who orders that for you? How do you get that? What's step one if you're a guy sitting at home watching this wondering, all right, good advice. I got to get on this. What do I do?
It's usually ordered by your primary care.
Go to your primary care.
Go to your primary care. And I think particularly if you're having some symptoms that you're not sure of, right? So I think in general, we talked broadly about screening and the blood test, but there may be some early symptoms that are also associated with prostate cancer. If you're having some urinary concerns, some discomfort with urination, getting up a little bit more at night, it's probably not cancer, but like if you're having any general concerns, talk to your primary care. And a PSA screening test will be an important part of that evaluation.
Awesome. Doctor, thanks so much for taking time today.
It's my pleasure. Thank you.
All right, folks, you heard it all here. If you missed any part of our program today, you tuned in a little late, maybe you had something else going on. I don't know what could be more important than this program. But in the event there was, go to subscribe to our YouTube channel, go to our website, atlantichealth.org. If you want more information specifically on prostate health or any of the services we provide, atlantichealth.org/prostate. For Dr. Rahman, I'm Luke Margolis. Thanks so much for joining us, and we will see you next time.